Okay, March the 19th, this is COVID video number 3. Now, moving forward, even after reducing our call volume sometime next week, we're still going to encounter patients that have flu-like symptoms. Some of them won't have the COVID virus at all, ever, and they'll have the flu. Some of these precautions are universal. We should be taking these anyway. But we should approach patients, particularly patients that are reporting elevated temperatures, difficulty breathing, as suspect for the virus. And as a result of that, make sure that we're making appropriate decisions with regard to PPE selection and distancing ourselves. Now, part of their defense, as I said in the previous video, is maintaining this 6-foot barrier. And where possible, also limiting the exposure to no more than 1 crew member. Now, with this, and in a discussion that I had with AMR this morning, we're also going to encourage you, where you can, to wait on AMR. AMR's giving their crews instructions to leave you outside, particularly on these types of cases, and they will take them. They understand and support this idea that we have a mission that's bigger than just medicals, and that protecting our force so that we can respond to the rest of our mission is important. So where you can, wait on AMR. Begin your assessment from 6 feet or more, and limit your exposure to no more than 1 crew member where possible. Now, some have expressed some concerns about the patch that's on our right shoulder. And this idea that somehow this patch requires us to treat that patient within a certain time frame. What I recall from our training was that that patch on your right shoulder requires you to treat the patient and to do so to the level that you're certified. For a conscious and alert patient who's sitting up, able to talk to you in no apparent distress, there's no federal, state, or even ethical mandate that you approach that patient within some number of seconds or minutes. Think about that for a minute. I'm imagining we've all encountered kids that are sick and scared. I also imagine that none of us just rushed in and immediately insisted on taking a blood pressure or listening for lung sounds if the child was not in more critical condition. There is no requirement that we get a pulse or a blood pressure in this window of time for a patient who's alert and oriented and is showing no other symptoms of being in distress. I get the fact that we're all required to do a complete patient assessment before an intervention. I get that. And I'm not asking you to change any of that. I'm not proposing that we modify any of our procedures and protocols. I'm suggesting to you that stopping at the door frame, inquiring, Mr. Smith, what prompted you to call 911 today? I have this fever, it's been here for several days. And then being able to process that information in terms of verifying you've got the right PPE, letting your crew members know that only one of us is going to go in, and then do your patient assessment. We are going to have to come into close contact with patients. There's no question about that. The issue is making certain we've built in just enough time that you can do an effective situational awareness, make appropriate PPE choices, make appropriate decisions about how many of your crew you're going to expose in that close contact before just rushing in. Cases where the patient's condition warrants immediate action, then you're going to have to take immediate action. You're not going to have a choice. And it's going to likely include some very close contact. So do so. But do it smartly with full PPE, and where possible, still limit the number of members that are in close proximity. I believe that if we were all in a room together, we could set up a number of scenarios where I could provide patient contact in close proximity. And even on some of our more advanced cases, keep most of the other crew outside of that 6 feet radius. That's what I'm encouraging you to do. So let's talk a little bit about exposures. In one of the documents that you're going to get, and is a chart, and it begins on page 4. So the interim U.S. guidance for risk assessment includes a chart that starts on page 4. In the version that I have, I've actually highlighted some things just so it was clearer for me, so I could find it. What the chart shows is a couple of things. It talks about the risk factors and how those risk factors lead to any work restrictions or the need for any kind of isolation or monitoring. And what you'll see in this chart, and again, it's the same chart that's in the Amarillo document, which will ultimately be in our Chief's Directive, is that according to the CDC, they've broken this chart into 2 segments. So the first segment is a prolonged close contact with a COVID-19 patient where the patient is also wearing a face mask. And the second chart is prolonged close contact with a COVID-19 patient who the patient was not wearing a mask. Same patient with a mask and without a mask. And in both situations, what the CDC says is if you're in full PPE, including a face mask, then there is no need for any work restrictions or isolations if you're asymptomatic. So close exposure, whether or not the patient had a mask on, if you're in PPE, and even if they are positive, there is no recommendation for quarantine as long as you're asymptomatic. And we'll come back to you being symptomatic in just a moment. What they do recommend is self-monitoring for a period of 14 days. So if you have come into contact with a patient who proves to be positive for COVID, and you're in full PPE, you don't need to be isolated, but the CDC says you need to be monitoring. And monitoring includes temperature readings several times a day for 14 days. Now, what we're currently working on is getting thermometers for all of our stations. We're also working on putting in place a process and a tracking system to begin to log those results, because we might ultimately get to a point, maybe not too far down the road, that we're just going to start routinely checking everyone's temperature as you arrive in the morning, and check your temperature maybe midday and check it again before you go home. That may be something that we're able to put in place here pretty quickly, but we certainly would have that process in place for anybody who has a COVID or a suspected COVID encounter. Now, if you begin to develop a temperature, and what the CDC says is it's at 99.4. According to AMR, they believe that that might be lowered by a tenth of a degree. They believe that that might be coming down to 99.3 to catch you just a little bit earlier. If you begin to show a temperature or any other signs, then the recommendation is to quarantine at home. So there is no central location being contemplated. We don't have a facility that could house folks that are quarantined other than a fire station. We certainly don't have a staff to maintain it. Quarantining you at home means you have access to your own bed, your own clothing, food, water, and we move you away from others that you might expose in this process. Now, I realize that that moves you closer to your family, but what it does is also empowers you to make the decision of what you do at home. Do your wife and kids go to grandma's? Do you go to grandma's? Or there's something else that works for you and your family? The CDC recommendations include distancing at home. And in fact, I'm gonna look at this other screen. I'm gonna read to you directly from the IAFF website. They have under their coronavirus disease 2019, they've got a section regarding quarantine and isolation. And the IAFF website says members can be quarantined at home for 14 days with family members occupying the same residence, provided that members avoid close contact with family members and maintain a 6-foot distance. Self-monitor for any of the COVID-19 symptoms. Practice and maintain personal hygiene, e.g. constant hand washing. Avoid public contact and cooperate with local and state health departments. So what we're proposing to you is in alignment with, in agreement with, the IAFF as it relates to isolation. Now, if we were to have multiple members of a crew that begin to show signs, I have to begin to think through the process of the possibility of sending crew member after crew member after crew member home one at a time. Obviously, a scenario that wouldn't be healthy for any of us. There is likely a point in time, if it were to look like multiple crew members in a single station have been impacted, that we might have to make a decision to brown out that station for a few shifts, bring in an outside organization that would do decon for us, and then move healthy staff back into that station. We've already been in contact with service masters and some others to begin having some dialogue in the event that we need this service, so that we have them on reserve. But at this point, we're not, we don't have specific plans for doing that routinely. Again, if we are using PPE, if we're only exposing one staff member, one crew member to that patient, we should be able to avoid that situation in most cases. All right, let me try and answer some of the additional questions that I don't think the last two videos or this video thus far has addressed. These have been raised and forwarded up through the chain of command. First of all, I'll tell you that to the extent that we haven't answered all of your questions, I want you to continue to send them up through your battalion chief. I don't think any of us need to be afraid of asking questions, and I'm going to do the best I can as quickly as I can to get you answers. So a couple of them that I've got for you here. Yesterday, prior to even getting the question, I verified with HR that if you develop symptoms and they're a result of a patient contact, we will be treating that as a work-related injury. Now, in order to do that, we're going to have processes in place. We're going to have to do first report of injury, just like we would perhaps an exposure to a hazardous material or some other bloodborne pathogen, as we already have processes for today. We'll still have some work to do over the next couple of days to figure out how and when and to whom do we make those reports. Another question had to do with decon of equipment and personnel. Well, again, if we're following all of the recommendations above, there should be very little need to routinely decon of equipment and crews. If we do need to decon, we're going to do so. We're going to follow the CDC recommendations. One of those documents I just showed you was their document on cleaning and disinfecting. They list, I think, more than 3 dozen products that they're recommending that we use for that purpose, and we'll continue to make sure that those products are available to you. Another question had to do with tracking of our known PUIs, persons under investigation. We'll continue to track all known PUIs. We have a mechanism already set up. That's how those alerts are getting into the dispatch system. We are also working in cooperation with the health district, health department, and AMR to discern the outcome of those tests, and then identifying any crew members that may have been part of that patient's care. So we'll be able to connect the dots based on the systems that we already have in place today. We currently don't believe that additional reporting is needed. We'll refine that as we go along as needed. And then I think another question had to do with spread within our environment. And this might be the hardest one to wrap our head around, and certainly one of the ones that's hardest for me to struggle with right now. One of the documents that I'm going to send you responds to this question of how is the virus spread? And at the very top of the document, even the CDC says COVID-19 is a new disease, and we are still learning how it spreads, the severity of illness it causes, and to what extent it may spread in the United States. We do know that what's important is several things. Personal hygiene. We just cannot express it enough. It's washing your hands constantly, and then just becoming very aware of all the things that you touch after you've washed your hands, particularly coupled with the number of times that you're touching your face. Second is this 6-foot rule. And we know how important that is, yet I know how difficult it's going to be in a firehouse. Your bunks aren't 6 feet apart. You know, there's not enough seats at the dining room table to have everybody 6 feet apart. Cleaning, personal hygiene needs to become a routine part of every single day. You know, the time that you're not doing inspections, I suggest you find something to clean. We are going to all have to continue to be vigilant about our own health and protecting each other. The really good news in all of this is the CDC believes that the spread of the virus is directly connected to the severity of the symptoms. That the earlier you catch this, the less likely that you're spreading it. It's not out of the question that one of our members might have been exposed and could very early spread it, but the CDC believes that it's highly rare, and that's why this temperature is set so low. I mean, at 90, if it gets to 99.3, you're talking about just over a half a degree change in temperature, and we move you out of this space for isolation purposes. And at that early in the process, you're at the lowest possible transmission level according to the information that's currently available. And I say all that relying on the fact that all of us, including really smart people at the CDC, are learning some of this as we go. I hope that in some ways these videos have helped at least get you up to speed. We'll have to do a lot of these or weekly updates to keep you informed. And I'm doing everything I can to help lead us through this. For me, this is why organizations have leaders, is to lead organizations through situations like this. Virtually anybody can lead an organization through times that are easy and times where things are going well. I hope that what you hear from me tonight is my concern for your safety and the effort that we're putting into making sure that we're doing all we can to balance between your safety and providing a service to the community. Remember, we're all they have. When they lose hope, they call the fire department. And in this situation, they're going to lose hope in terms of their ability to cope with sickness. And they know that they have men and women that they can count on who will respond to their needs. We're going to continue to do everything we can to support you, keep you informed, try and sort through fact from everything else that's out there, and try to keep this boiled down. There are literally thousands of articles that are out there I'm going to send you 3 documents, but what I need you to do is read them all, and I need you to process through them. I'll try and synthesize what I think is helpful to keeping you informed, and know that I'm going to stay awake at night, making sure that we're doing everything we can with all the energy that we can to keep us all safe. I want to thank you all for your continued service. I know these are tough times. We will get through this, and we're going to be stronger because of it. And we're going to be able to look back and celebrate how well we did this together. I pray a blessing over every one of you, your families, that God keeps us all safe, and that together we become stronger, tighter, and closer organization. Thank you so much for listening. Forward those questions up through your battalion chief. Have a good evening.